IUSG Grand Rounds on behalf of IUSG. And this particular format represents the iconic institutes all over the world. We started with none other than Moorfields, followed by SNEC Singapore, and now is the turn of my institute, which I'm so proud of, from India, PGI Chandigarh. So we have a team with us. Rima, you all know, she has been there, and Simar is here as well, our younger consultant. Since our forte is mostly the infection, so we are going to show the cases representing infections and how confusing the world of uveitis can be. We have Carlos as our panelist and John, who will give us further insights as we go along. So welcome you all to the Grand Rounds. Now coming to the IUSG. Well, welcome you all. You all have CME credit hours, European CME accreditations. You know the drill. You have to write a mail to our back office and you will get the certificate. It's also my proud privilege to announce the winner of last month's Grand Round, which is by SNEC, and the winner is Tommy N. Brown, who presented Behind the Veil of Inflammation, Unmasking a Clinical Imposter. Congratulations, Tani. And the winners, we are going to have a beautiful book by IUSG, which is called Global Cases, Global Scenarios, Real World Cases. And that book does not have the knowledge from the textbook. That has the knowledge from the experience, a knowledge which you cannot get from chat GPTs and Geminis and Google, a knowledge which comes straight from the brain. And the book is going to be hopefully ready by ISU in Tübingen, which is in July. And whenever we release, we will be very happy to share the soft copy of the book as a prize to all the winners of the previous Grand Rounds. With this, I will pass it on to John, who is the chair of our education committee, to lead today's webinar. Welcome, everyone.
Yes, well, thank you everyone for joining. And I should acknowledge that Rima did most of my work for organizing this session, which I was supposed to organize, but because of some family issues, Rima kindly stepped in and did most of the work. So thank you so much, Rima. And so we have the extremely illustrious Advanced Eye Center Postgraduate Institute from India group leading our session today. And the first faculty is none other than Vishali Gupta, who is the president of our society, as well as being professor and chief of uveitis and vitreoretinal surgery services at the Advanced Eye Center. And also she's president of the Vitreoretinal Society of India and past president of the Uveitis Society of India. And the fellow working with her is Dr. Chaitanya. So let's go ahead and have the first case. And thank you for presenting it. Diagnostic pitfalls in uveitis, clinical acumen surpassing laboratory findings.
Can I start, ma'am? Greetings.
Yes, please.
Thank you, sir. Greetings to the esteemed members of the panel, respected faculty and colleagues. The patient's history dates back 5 months prior to his presentation to us, and this portion of his clinical course will be presented based on the available records. He is a 31-year-old man who had presented with chief complaints of diminution of vision both eyes of 3 months duration, which was insidious in onset and gradually progressive, with a history of sudden worsening over 10 days. He was a frequent traveler and had given history of high-risk behavior. Visual acuity in the right eye was noted to be hand motions, intraocular pressure of 14, anterior segment showed no cells or flare, vitreous cells were noted to be absent, and the fundus examination was significant for presence of cotton wool spots-like lesions, retinal hemorrhages, and occluded vessels in the periphery. The left eye had light perception, intraocular pressure was normal, anterior segment showed no cells in flare, vitreous cells were absent, and fundus examination showed cotton wool spots, retinal hemorrhages, and occluded vessels. OCT reflected presence of macular thickening with fluid in both the eyes. A fundus fluorescein angiography was also available, which showed features suggestive of occlusive retinal vasculitis in both the eyes. At this time, provisional diagnosis of bilateral occlusive retinal vasculitis was made, and oral steroids 1 mg per kg per day was started, and lab investigations were ordered. 5 days later, the patient was noted to be stable and in fact demonstrated to have reduction in the fluid on OCT. Reports were also available at that time which tested positive for HIV, VDRL in 1:160 titers, and TPHA. With this background, ocular syphilis with HIV was diagnosed, and intravenous ceftriaxone therapy was initiated for 2 weeks. Oral steroids were continued in tapering doses. 2 weeks later, after the patient had completed IV ceftriaxone therapy, right eye visual acuity was noted to be counting finger at 2 meters, an improvement from the presenting visual acuity, and first sitting of scatter laser was given to the capillary non-perfusion areas in both the eyes. At this time, CMV DNA reports were also available, which was not detected in plasma, and antiretroviral therapy was initiated. So the timeline till now showed that on presentation, patient was diagnosed with occlusive retinal vasculitis, oral steroids and was started and labs were ordered. Once HIV and TPHA positivity was confirmed, IV ceftriaxone therapy was given. And thereafter, 2 weeks later, after finishing ceftriaxone therapy, antiretroviral therapy was initiated. Further in the course, the records reflected 2 sittings of FFA-guided scatter laser, continuation of antiretroviral therapy, and a dermatological review, which revealed presence of genital ulcers, which were deemed to be herpetic in nature, and acyclovir was started for the same. On 5th May, that is 1 month later, the patient was noted to have a worsening of vision, which was of sudden onset in the right eye especially, and the fundus picture showed presence of these whitish lesions with an advancing edge very close to the posterior pole in the peripapillary retina in both eyes, left eye more than the right. This was associated with a recently demonstrated rise in the CD4 count. In addition to the syphilis, CMV retinitis and immune recovery uveitis were added to the differentials. An aqueous tap was performed, which was reported as negative for panviral genome, CMV, HSV, and VZV. VDRL titers at this point were demonstrated to be significantly lower but not non-reactive, and patient was started on valganciclovir induction therapy and restarted on ceftriaxone course. 4 days later, the lesions appeared to have become more confluent, but a week later, there appeared to be some regression and some improvement in vision was demonstrated. So from 5th May to 14th August, the patient was on valganciclovir, which was tapered to maintenance dose after 3 weeks of induction. IV ceftriaxone was repeated for a course of 2 weeks. In the meantime, a dose of ganciclovir intravitreal was given in each eye 3 days apart. Low-dose prednisolone was added, and an intravitreal ceftazidime was also given in each eye, 1 dose. Initial improvement and then plateauing of vision was demonstrated. Then a dip was also demonstrated somewhere around mid-June. This is the time the patient was first seen by us. It was 14th August. The visual acuity in the right eye was counting fingers, and the left eye had become PL negative with extensive involvement, while the right eye showed several areas of ill-defined, indistinct advancing edge, almost 360 degrees. The patient was admitted, and an induction therapy with intravenous ganciclovir 5 mg per kg twice a day was initiated. In addition, aspirin as well as prednisolone 50 mg was started. The patient was also taken up for intravitreal foscarnet twice weekly regimen in the right eye, 2.4 milligram per ml. This is 2 weeks later when the visual acuity had improved to 6/16, and a comparison from the baseline presentation to us demonstrates the borders which were earlier ill-defined becoming more distinct, while the lesions involving the inferotemporal and inferonasal retina had resolved almost with no sequelae. So over the next 3 months, the induction therapy was with IV ganciclovir, which was followed by valganciclovir oral 900 mg BD in induction dose. Aspirin was continued and prednisolone was given in slowly tapering doses. Intravitreal therapy with foscarnet twice weekly regimen was continued for a month, and only after demonstrating stability and no further improvement of the lesions on fundus photography was it switched to ganciclovir once a week regimen. We continued that for 2 more months, and thereafter a further stability demonstrated led us to increase the interval between two intravitreal doses. This is how the patient progressed thereafter. We can see with every visit and the regimen that was followed, there was more distinction of the advancing edge, and eventually there was regression of the lesions which were demonstrated earlier. So the strategy was to closely monitor the advancing edge of the lesion. Initially, the patient was under very frequent follow-ups. Intravitreal therapy was switched to ganciclovir only when stability was documented and ascertained. Gradually thereafter, the interval between subsequent injections was also increased. Systemic valganciclovir maintenance therapy was started only after 3 months of induction therapy. All this time, the renal functions and the blood counts were monitored and they were within normal limits. The patient had followed up very recently, where the visual acuity had improved to 6/36, and the lesions can be seen as quite distinct with distinct borders all over. Thank you.
Thank you, Chaitanya. Can you stop sharing, please?
Yes, ma'am.
Perfect. Now let's go over this case, which teaches us that sometimes the labs do not really do justice. So the title which I have given from discussion is From Clues to Catastrophe, the case which highlights critical missed steps. Now let's go back to the case. This is the patient and this is how the patient presented. He is HIV positive. He has not received any treatment. There are, in fact, no signs of inflammation. Since I have not seen patient at this point of time, I can tell you only what was available in the records. There were no sign of inflammation in the anterior segment or Uveitis. So what was seen predominantly and has been shown by Chaitanya, the vessels which are getting occluded, hemorrhages, and areas of ischemia which were noted. There was thrombotic arthritis, which was not seen, and I wish I could zoom it for you, but this vessel, this artery, when I was zooming it up, showed the arthritis. What was also not mentioned in the records was this small granular lesion, which was in the periphery. So at this point, a diagnosis of occlusive vasculitis was made, and the patient was started on oral steroids while waiting the investigations. Subsequently, the tests which came positive for syphilis, but right now they did the angiogram, and on angiogram you can see the right eye, of course, shows the occlusion shown by Chaitanya, but look at these lesions which are in the far temporal periphery. The larger image in the back shows when the patient presented. The smaller image shows that these lesions have increased, and oral steroids were given, but when I was looking from the point of discussion, what would I have done different? I think instead of simply calling it occlusive vasculitis, I would have paid attention to these lesions in the periphery. And I do have the privilege of Silverstone. I would have done peripheral OCT to characterize to see where exactly these lesions were. Even if I could not get much information, I would keep these lesions under very close watch. And I have encircled those lesions for you. Now, what happens 5 days after the steroids? 5 days later, patient is on oral corticosteroids and there is a progressive ischemia and occlusion and some new vessels. For example, in the right eye, if you look at the nasal vessels, they were not occluded before, now they are getting occluded. And even in the left eye, if you compare the top, which were at the time of initiation, and bottom, the bigger ones, the vessel occlusion is increasing. What is also increasing is this green circle temporally in the right eye, these lesions which are increasing, and even in the left eye, in the lower temporal, some of these lesions are there. Now, at this point, the test come positive for syphilis. So you ask yourself a question, could it be syphilis? Well, why not? HIV patient, syphilis positive. Would I treat it for syphilis? For sure. So that is how the patient was given treatment for syphilis because patient had endarthritis, occlusive vasculitis, retinal hemorrhages, which would fit in with the diagnosis of syphilis. What was a little odd was there was no inflammation, but then patient was HIV. We did not see any placoid or any other lesions. So again, patient is not seen by me at this point. Treatment for syphilis was given, and I totally agree anybody would treat for syphilis. But even though you would treat it for syphilis, I think it's very important to monitor the response very closely for any new lesions or anything which is evolving and you are not comfortable with. Because if it is purely syphilis, it should start responding to the treatment in some way. Now, during this, where I was very, when I'm talking to you, my focus of attention would have been those temporal lesions. And somewhere the laser was added. Now, if you look at this, the laser and those lesions are so mixed up that it will be very difficult to monitor those lesions. So when we are doing such kind of interventions, probably we have to demarcate the areas we want to monitor because of the laser, we could not monitor. Now the patient's vision is going down and the left eye at this point is light perception only. And then I don't know what happened in the next 3 months. Chaitanya has given you a lot of detail, but right eye, you can see progression from this to this. At this point, they did think of CMV, but since the CMV was negative both from the PCR and from the blood, the ganciclovir injections were given like once in a blue moon sort of a setting, and not a full-hearted treatment was given. A possibility of resistant syphilis was kept, and even intravitreal ceftriaxone and all were also given. But you can see between March to May, the disease is progressing, and so is the left eye. So they received treatment for resistant syphilis and CMV, not the full-fledged treatment. And then over the next 2 months, the left eye, is blind, no PL. And this is what was happening in the right eye. Now, this is the time when I saw the patient for the first time. So what will you do? To me, it looked like CMV. And I did not, honestly, at that point, there is nothing to lose. The patient has become no light perception in one eye. The other eye is looking like CMV to me. So I just went all out without caring for labs and just treated it as CMV because the other eye had already been no light perception. So this is what Chaitanya has already shown, that there was a lot of component of fibrosis, which of course we could not take care of. But the active lesions with the fuzzy borders and the new lesions which were appearing, we could take care of this, and the patient is at least mobile, seeing two lines, whereas the left eye remains no light perception. So what I want to talk you to today about the next three slides is not about science. It is actually a case, what I call it as cognitive dyscalia. This happens when automation, habitual shortcuts replace the active clinical reasoning. And why does it happen? There are multiple biases which can cause it, which could be automation, too much over reliance on protocols, anchoring bias, or delegation of thinking. Delegation of thinking is somebody's made the diagnosis, it kind of clouds your judgment. For this case, I think it was an anchoring bias because syphilis was positive and it was treated for syphilis, but somehow that syphilis was so much sticking to the mind of the surgeon that there was a failing to reconsider the possibility of something else happening. So, how clinicians can prevent it? It's important to have a diagnostic pause. Consciously reconsider the differential. There is important to do an independent verification. You review the data, you take out all the old records, take out all the old imaging, see what is happening at what point. It takes a lot of time, but I think in cases like this, it's very important that you review your own data, you maintain a broad differential, and don't do the premature closure. For example, you know, try even if your labs are not supporting you. It does not happen every day. It's sometimes it happens, but if this happens, I think your clinical judgment is extremely important, and you should look at it. So with this, I would like to invite our panelists, Carlos and John, to give their comments.
Thank you, Vishali.
Great.
Fascinating case. John, you want to go first? I'm happy to
Well,
go if you.
I was curious about did you ever find out the CD4 count of this patient?
Yes, we did. I did mention the CD4 count was
Okay.
low in the beginning, but they picked up very quickly after the heart, and then they became 654 or something. Chaitanya,
Wow.
you will.
Okay.
Yes, ma'am.
So
54. It had increased and then maintained those levels.
Yeah.
I would like to just point out from the old days, we know that the mortality risk of the people with active CMV retinitis and AIDS is exceptionally high, about double the risk of of an equivalent patient in terms of the CD4. And the CMV seems to transactivate the HIV and vice versa. And so this is why there's also a high risk of retinal detachment. So those are just some teaching points. Um, and or for the audience, I was wondering, Vishali, could you sort of go over like the thought process between differentiating it between CMV and ARN?
Process between CMV and non means? Oh, you want me to
Sorry,
talk about
acute
it?
retinal necrosis, acute retinal necrosis. Yeah, like what are the features that favor CMV versus ARN? It ends
Okay.
up kind of looking confluent, and there was ischemia, things that might have been with ARN.
Yes, John, traditionally, when we talk of the herpetic retinopathies, we always thought that the vascular involvement was typical for ARN, which was VZV and HSV. And I
Hmm.
think of recent, I saw about 3-4 patients of pan-occlusive vasculitis in CMV without retinitis. I asked Ilaria. Ilaria presented the most beautiful
Right.
cases in the first grand round. And about 2 months ago, I asked her, I said, "You want to pool the data?" She said, "Oh, we just submitted ours for publication." That
Okay.
that besides the point. The point is that now the vascular occlusion, I do not think it as a differentiating feature between
Hmm.
CMV and HSV or VZV, which used to be very prominent in the past. And I think Carlos can elaborate more about it, about this pan-occlusive vasculitis as a presenting, because this patient, when he presented, the predominant feature was occlusion. We did not have features of CMV at that point of time. They came almost 8, 9 months later. So I will switch it
Right.
to Carlos.
Thank you, Vishali. Thank you, John. Well, yeah, there's very interesting points to discuss about this case because normally when we look at CMV retinitis in the setting of the HIV patients with low CD4 count, what will be the predominant feature is the retinitis itself. We'll present very early on. What we have here is an inversion of that. You have the occlusive vasculitis as the first feature, and then the retinitis came a bit later on. And probably what happened here is the addition of the steroid facilitated that to progress more rapidly. So you already had an immunocompromised status, and you added the steroids to treat the occlusive vasculitis, and that made the situation even worse. So I think you attract attention to a very important point, and you made very clear comments on that. We sometimes jump into conclusions based on the most obvious finding, but if we pay attention to the detail, we may find clues that will tell you, wow, this is not fitting very well what should be happening here. So the case you referred to from the Morpheus presentation was an individual who was on HIV. He was just receiving immunosuppression for a picture which originally was a retinal vasculitis without occlusion, and then he converted into a picture of an anterior uveitis plus occlusive vasculitis. So the immunomodulation we gave him to try to treat the vasculitis probably triggered the behavior. So the CMV is affecting the endothelial cells of the vessel. So the occlusive disease is happening because of that. That's where the damage is happening. And I think the moment you immunosuppressed more, that's when the disease became a retinal infection per se, rather than just a contained vascular problem. I think if that patient presented without a history of HIV and maybe in our setting here, we've seen recently at least one great example of a lupus-related vasculopathy in which the individual presented with cottonwool spots and ischemia and needed laser all over the place. It was no piece of, not a bit of inflammation in that eye. It was just a vascular occlusive disease in the setting of severe lupus affecting systemically as well. So clearly that image you showed at the beginning makes you think of a systemic problem. That's one feature. You think about that. And of course, the HIV situation then makes you think of an infectious process coming on the back of this immune status. So we have seen this in many patients in which there is occlusion, a few hemorrhages, and some patients don't even get the retinitis. You treat them, and the whole thing turns into just ischemia, and you treat the ischemic carriers. But in this patient, of course, as you say, we went from a clue to catastrophe because it was just a galloping deterioration of an infectious process that was missed in the beginning and allowed to take over. When you see all that occlusion, the virus is already all over the place. The virus is already there. All you did is you unleashed it by giving more immunosuppression. So that's when it became so widespread and so rapidly confluent because it's already in place, but it took advantage of the fact that we immunosuppressed more. So yeah, it's one of those things. It's that clinical detail that you showed right at the beginning would have made people think, what is this doing here? What is the reason for that to be there? And that's when you have to be more cautious about your approach. Agree, treating the syphilis is no-brainer. You have to. These patients also have co-infections. But that is not a syphilitic presentation, what we saw there. It didn't suggest syphilis in terms of the way you normally see it. But I think it's very important to highlight the potential of CMV causing this kind of occlusive phenomenon. And if you immunosuppress more, then you can get a very fast progression of disease.
Thank you. John, over to you.
Good. Yeah, I wonder if we should just wind up there because the first half hour has passed and we could go
Yeah.
on to the next case. But it's a very interesting case, and
Thank you.
people these days are not seeing too much CMV retinitis, so take every opportunity that you get to learn about it. It used to be very common, although it seems like we're seeing more unusual cases now when we see them, maybe because the immunodeficiency isn't so much like it used to be, like the Titanic going down, the clinical course of the AIDS patient, and they never got better, and it would behave in a more predictable fashion when now there's immune recovery happening. So
John, just one
good.
quick question to Vishali before we
Yeah.
move. Vishali, the negative PCR, it was taken from the AC or from the vitreous? Where was it
AC.
taken from?
It was done from the AC.
From the AC. But the AC wasn't very active, right? You said it
It
was.
wasn't very
So
active.
that is the problem. That's
Yeah.
why it was negative, probably, because you took from an area where there's not much going on. Yeah.
So when
Okay.
we gave Foscarnet, when we took over, we did from the vitreous, but by that time, 2 injections of GAN were
Yeah,
already
yeah,
given.
yeah. Okay. It's just a
Yeah.
good thing because many times I see PCR negative and people say, well, I took it, it was negative. I say, how inflamed was that eye at the time you took your sample? And
Yeah,
if there's no inflammation, the chance of finding is very small. Okay.
agree.
Thank you.
And isn't the positivity rate something like 80%? As I remember, maybe I don't have the latest, but there's certainly room for false negatives. Yeah.
True.
So I wanted to just interrupt for a minute to talk about our course coming up next month, the third basic uveitis course in Africa, which has 31 and a half hours of European CME credit and an illustrious faculty, and easy to get to Addis Ababa, and as one of the major airlines, and you don't have to traverse the Middle East, although hopefully things will be better by then. I'm going to just put the link for registration for this course in the chat, or I may have to ask the hosts to do that. But we'll put that in the chat for those of you who might be interested. Very similar to the course that we've been having in Venice and in other places recently over the years. Okay, so let's move on to the next case. And I sort of set myself up without the prompt here, but it's Dr. Professor Rima's case. And why don't you go ahead and present the next one? Oh, thanks for sending it in the chat there. So Rima, can you please proceed?
Dr. Sumedha will be presenting the case of an atypical posterior uveitis unfolding the unknown. Over to you, Sumedha.
Thank
Very
you.
good.
Thank you. Greetings, everyone. So my case is a case of atypical posterior uveitis. She was an 18-year-old female who presented to us for the first time on the 27th of December 2024 with decreased vision in the left eye of 2 months history. She had no history of trauma, flashes, floaters, or recent febrile illness. There was no history of high-risk behavior. Review of recent medical records of treatment elsewhere revealed that she was diagnosed to have left eye active choroiditis with cystoid macular edema and was started on oral and topical steroids, after which she worsened and she was referred to our center for further management. On presentation, her visual acuity in the right eye was 6.6 and in the left eye was, counting fingers close to face, intraocular pressure of 10 in the right eye, 9 millimeters of mercury in the left eye. The pupil of both the eyes was central circular reacting to light, and the anterior segment examination of both the eyes was within normal limits. The fundus examination at the posterior pole of the right eye appeared within normal limit. However, in the left eye, there was a media clarity of grade 1. The optic disc was normal in size and shape. The vessels appeared tortuous in course and caliber along the arcades, and there were new vessels seen emerging from the inferior arcade. There was perivascular sheathing and cuffing. Also, there were creamish exudates that was seen at the posterior pole, and the serous retinal detachment was also seen. The periphery of the right eye was within normal limits. However, in the left eye, the serous retinal detachment, the extent was from the superior arcade and it extend inferiotemporally beyond the inferior arcade. So the impression so far, we knew we were dealing with an infective morphology which was subretinal, and our plan was multimodal imaging. So we did an HRA OCT DEN scan and we did an FFA and an ICGA. So the OCT showed vitreous cells. The hyaloid was thickened and it was partially attached. There was retinal thickening. There was shadowing or choroidal shadowing. There was smudge effect seen, and there was a lot of loss of retinal architecture, the layers, and the choroidal vessels could not be seen. The FFA and the ICG of the right eye was within normal limits, and in the left eye at the early frames there was a loss of background choroidal fluorescence, which was corresponding to the area of the serous retinal detachment, and there was early hyperfluorescence and late leakage at the macula. There was also perivascular leakage along the inferior arcade. So with this we made a working diagnosis of left eye retinitis, which was likely because of Toxoplasma gondii, viral HSV or VZV, or syphilis. So the plan was serology and TPHA. The patient came positive for IgG for Toxoplasma gondii and the other tests were negative. So she was given intravitreal clindamycin 1 milligram per 0.1 ml and dexamethasone 400 micrograms per 0.1 ml in the left eye. She was also started on tablet Septran double strength once daily, and 48 hours later she was started on tablet prednisolone 40 mg once daily. So after starting the treatment, the exudates appeared clearing centrally, and also the OCT showed improvement in the vitritis and the retinal thickness also reduced. So the patient received a total of 5 intravitreal injections, and at the last intravitreal injection, the lesion, the serous retinal detachment had resolved, and there was subretinal, the exudates had also resolved significantly, and the patient's visual acuity improved from counting fingers close to face to 3/60. The OCT also showed significant improvement. There were no vitreous cells, the retinal thickness had significantly reduced, and now the choroidal vasculature was also appreciable. So far, the patient had no history of immunocompromised status. The ocular lesions were resolving, but the patient seemed lethargic and confused. So we planned an MRI brain with orbit for the patient, which showed a well circumscribed globular lesion in the right thalamus with an iso-intense central core suggestive of cerebral toxoplasmosis. On further evaluation, the patient tested positive for HIV. So we took more history. The mother had passed away at a very young age. The cause of death was unknown to the relatives. The father was advised for an HIV testing, and she was referred for antiretroviral treatment. At the last follow-up, that is on the 20th of March 2025, the lesions appeared stable and the visual acuity was maintained at counting fingers at 3 meters. So far, we had a case of Toxoplasma retinochoroiditis, which worsened because of misdiagnosis, mismanagement, and due to the immunocompromised status. Thank you.
Thank you, Sumita.
Thank you very much. Yes, go ahead, please. Thank you, Rima.
Can you see my slides?
Just
No, Rima, we can't see.
just the files right now. Maybe the file is the one open and not the slide. The list of files and not the slides.
Okay.
Is it open
So
for you?
maybe,
For me, it's open.
yeah, so maybe you unshare and then share again the one that's open. Because I think when you it may.
Yeah,
Yeah,
we
there we
can
go.
see it now. Yeah, perfect.
So thank you, Carl. So moving on with this case that Sumedha presented. So this was an atypical posterior uveitis, and so far you've seen this was the picture where the 18-year-old girl presented with counting fingers close to face. On closer look, the lesion was this bad and this aggressive. Now we know we were dealing with ocular toxoplasmosis. But coming to the spectrum of atypical presentations of ocular toxoplasmosis, it can present with large or multifocal or bilateral lesions. There could be neuroretinitis, punctate outer retinal toxoplasmosis, occlusive retinal vasculitis with retinal or subretinal neovascularization, optic nerve involvement, rhegmatogenous or serous retinal detachment. Pigmentary retinopathy has also been reported that mimicked unilateral retinitis pigmentosa and very rarely, scleritis. Coming to the past records, which Sumedha mentioned, I will show the photographs. This is how the patient presented to the ophthalmologist elsewhere. And there was this single focal lesion in the fovea. And if you look at the OCT, there is full thickness retinitis, there is cystoid, there is intraretinal edema, probably, which was mistaken as cystoid macular edema. And that is why the patient was diagnosed as an active case of choroiditis with cystoid macular edema, leading to initiation of oral and topical corticosteroids. When at 3 weeks, the patient worsened with the primary ophthalmologist with these findings, the patient came to us. Now, this was a case of a necrotizing infectious retinitis, and we know the diagnosis is primarily clinical and with laboratory findings which help in corroborating the diagnosis, like serology. OCT is, of course, very important for differentiating various causes of infectious retinitis, and we have a number of articles on the OCT findings of toxoplasmic retinochoroiditis. But what is important is when we saw the OCT findings of our patient, which Sumedha mentioned, I would like to go into detail of this one particular article which compares the OCT findings of different infectious retinitis, mainly toxo and viral. So the OCT findings of the vitreous in toxoplasmic retinitis have been reported as hyperreflective oval deposits on the inner retinal surface, and the small squares that you're seeing on the right of the main photo are nothing but the magnified view of the lesion that we're talking about. There could be there. This is characterized also by the presence of hyperreflective round-shaped deposits on the posterior surface of the hyaloid and on the inner surface of the retina, which are actually they resemble like mirror image deposits on the retinal surface. There's presence of retrohyaloid hyperreflective dots, which are more clearly seen on the enlarged view. Looking at these patients, the first and the third patients were immunocompromised in their series, and the second patient was an immunocompetent patient. Versus when we compare it with viral retinitis, the oval deposits that we saw in toxoplasmic retinitis in the posterior hyaloid and the back surface of the posterior hyaloid are not seen in viral retinitis. And it does appear thickened with some hyperreflective tracts, which are not very uniform, but there are no round-shaped deposits on the retinal surface. There are varying degrees of vitritis, which we can see here marked by the asterisks. And out of these, the first patient was immunocompromised, and the second and the third patients of viral retinitis were immunocompetent. Coming to the OCT findings of the choroid in toxo versus viral. In toxo, there is hyporeflectivity of the underlying choroid beneath the necrotic focus of retinitis, and there is absence of hyperreflective septae within the choroid, which suggests that there is choroidal architecture disruption. In contrast, in viral retinitis, there is no such obscuration of the underlying choroid, which largely appears preserved, and there is not much distortion of the choroidal vasculature. Coming to the OCT findings of the retina, in viral retinitis, there is intraretinal edema involving the outer nuclear layer with cystoid spaces, and hyperreflective vertical strips are seen within the outer nuclear layer at the margins of full-thickness retinal lesions, which have not been described in toxoretinitis. In contrast, the retinitis of toxoplasma produces a shadowing effect on the underlying choroid, where you cannot really see the choroid. So it's better to pass the scan through the edge of the active retinitis lesion, where you can appreciate at least the extent and the margins of the choroid underneath the lesion. And you can see that there is disruption of the normal choroid if you compare it with the adjacent normal choroid. This is the table that they have given, showing the difference between the two. And the ones marked in red are the significant findings that were seen. So in toxo, as I said, hyperreflective oval deposits on the posterior hyaloid, on the retinal surface, hyperreflectivity of the choroid, round shape deposits on the hyaloid, and disruption of the choroidal vasculature were significantly more in toxoplasmic retinitis in contrast to the viral, which had intraretinal edema and hyperreflective vertical strips in the outer nuclear layer. So coming back to our patient where Sumedha has already described these findings, I'm just showing the scan through this was the scan through almost the center of the lesion, but the same box, if we see the scan through the inferior edge of the lesion, we can very well appreciate the hyperreflective round deposits on the posterior surface of the hyaloid, as seen by the blue arrows, and the orange arrows show the mirror image deposits on the retinal surface, retrohyaloid hyperreflective deposits, and the choroidal vasculature cannot be appreciated. So these findings were all there in our patient, and which truly helped us to make an instant diagnosis of an ocular toxoplasmosis without even the lamps being present with us, which came the next day. So this was the response, as you can see, at 1 week, at 3 weeks, and at 2 months passing through the fovea. Now, this is the response. The patient did much better, but we couldn't avoid the subretinal fibrosis because of delayed initiation of the appropriate therapy. Coming to the cerebral toxoplasmosis, which was detected in this patient. So there are a few case reports of concurrent ocular and cerebral toxoplasmosis, and it is seen in immunocompromised individuals, particularly in advanced HIV, in individuals without treatment or prophylaxis. So just to pass through some of these articles on cerebral toxoplasmosis. Coming to the ocular toxoplasmosis in HIV positive patients, in these, the retinochoroiditis is most often acquired and it spreads from a non-ocular site elsewhere in the body. And that is the reason a scar is frequently absent in these patients of atypical toxoplasmosis. And often the retinochoroiditis is aggressive and atypical, as we have seen in our case. We need to differentiate between toxoplasmic and CMV retinitis, which we all know, but you have a much more prominent vitreous inflammation in toxo, an elevated lesion of focal retinochoroiditis, or an aggressive lesion of necrotizing retinitis in toxo, and relative lack of intraretinal hemorrhages in toxoretinitis. These patients are at increased risk of life-threatening intracranial toxoplasmosis, and a very old report, but very relevant. In a series of 16 AIDS patients with ocular toxoplasmic retinochoroiditis, 7, which is almost a little less than half, had concurrent cerebral toxoplasmosis. So these patients of ocular toxoplasmosis in HIV patients should be subjected to an MRI. And coming to the acquired versus the congenital, the previous belief was that the toxo is typically along a scar, which gets reactivated and produces an active toxoplasmosis. However, now there are increasing reports of acquired ocular toxoplasmosis, which presents as focal retinochoroiditis without any adjacent retinochoroiditis scar. Even in eyes with pre-existing retinochoroiditis scar, it is likely and it appears that the scar probably evolved during the course of the disease that was postnatally acquired and not in utero. So the parasite is able to disseminate from previously infected sites in the body to the eye and then causes acute toxoplasmosis later in the life within the eye. A population-based survey in Brazil revealed a relatively low prevalence of ocular toxoplasmosis in children up to 8 years of age and a higher rate in children more than 13 years of age. An ocular disease may occur in as many as 1 in 5 individuals suffering with a systemic toxoplasmic infection. To summarize, this was a typical presentation of ocular toxoplasmosis with a focal retinochoroiditis in the macula, which became atypical not only because of misdiagnosis and mismanagement, but also because of an unknown immunocompromised status of the patient. So the key points that we learned from this, the key OCT findings helped us to make a clinical and a prompt diagnosis of ocular toxoplasmosis. Detection of cerebral toxoplasmosis led to the diagnosis of HIV in an unmarried young woman without any history suggestive of the possibility of being HIV. So we do recommend a baseline HIV screening in some of these patients despite typical presentation of infectious retinitis. Thank you very much.
Beautifully summarized, Rima. So thank you so much. And I learned so much when I listened to you and Vishali. So Carlos, would you like to make some comments
Yeah,
first
thank
this
you,
time?
John. Thank you, John. Thank you, Rima. And thanks for the presentation. Yeah, it's a very interesting case. Lots of angles, again, for us to consider here regarding the immune status. That was my first question when you showed the slide in my mind of what's the immune status of this patient, because that kind of behavior makes you think that something is wrong with immunity. I think there's maybe some initial features of behavior different even in the early presentation, because that Vitrus didn't look very involved in the beginning, and the AC was quiet. So a few things were looking like a bit weird, and even at the very beginning. But of course, the way it progressed, and it was obvious that it was behaving in a way unexpected for someone who's immunocompetent and can control the infection in a limited way. So this was spreading and very fast. And one important thing, every time I have an HIV or immunosuppressed patient with toxo in the eye, my first thing is image the brain, because the risk of brain disease is even greater than the eye. If you have the number of cysts that are probably in the brain, much greater than in the eye, so the risk of reactivation is higher. When I was looking after the HIV patients back in the 90s, it was the most important cause of an intracranial abscess was toxoplasmosis in immunosuppressed patients. So it's really important to keep that in mind. The issue of the blood test, is very unhelpful in this case, because it came back as an IgG positive, which doesn't really tell you a great deal about what's going on. It's a test that patients coming from endemic area of toxo will have a positive test, and doesn't help much. And sometimes taking samples from these eyes is difficult as well, but you need to find the bug, which is not always easy with PCR and things like this. So a typical case is where you probably need samples somehow from the eye to confirm the diagnosis, unless you, as you did in your case, you had enough imaging evidence and supported by the thinking that this was toxoplasmosis. The one thing to mention is this interesting comparison between viral and toxo. I think it's very useful, but the choroidal thickness is not always normal in viral. We published several patients with viral retinitis in which the choroid is also thickened. So it's not a total differential there. But this issue of the hyaloid and those deposits there, I remember from my days of training, we used to call these incorrectly posterior KPs, because they look like KPs sitting on the back of the hyaloid. So exactly what you saw clinically is what you see now with your imaging. What they represent is the cells attached. And you can see the separation of the hyaloid from the retina. You can see the correlations there. So it's actually wanking things off the surface of the retina when the vitreous separates. So you have the correlation of the two things that are, mirror images, because it came from there. So the vitreous just got away from it. But this, you pointed out, you have to think about it at full thickness retinal infection. In this case, not much vitritis at all. The subretinal fluid, you showed a beautiful, very large serous detachment of that retina in the eye. And this happens because exactly toxo causes a choroiditis, and many times the choroiditis will affect the RPE and then result in the leakage that you see. Very small toxo lesions can do that. Interestingly, how the choroid can get involved. But I think the message here is, if you see something that is behaving in a very peculiar way, your first question, if you think it could be a immunodepressed patient. I'll mention just this because I learned a lot. I went to Brazil for a meeting. They showed a slide of multifocal toxoplasmosis in an eye. My first question is what's the immune status of this patient? And they said, there's nothing to do with that. This is primary acquired toxoplasmosis. So IgM positive cases, they can show multifocal choroidal retinal lesions in totally immune competent patients. So this is a feature of a primary acquired disease that can happen. In Brazil, they see it a lot, and I wasn't, even though I am from Brazil, I have been living in the UK for 35 years, so my number of toxo cases I see has gone down quite a lot. But clearly, some behaviors we have to keep in mind, they can happen. But if you see multifocal disease in outside that setting of IgM or behaving badly, think immunosuppression and look for the brain.
Thank you.
Thank you.
John, can I make a comment? continuing with what Carlos said, there are three questions related to differential diagnosis, and I would like to talk about them. Maha has asked, could it be TB granuloma? Well, when you look at it, it could be granuloma, but Rima showed that important thing is if you're suspecting a granuloma, pass a OCT through that. Now, TB granuloma clinically is large, single granuloma, yellowish looking, and you may have retinal hemorrhages or wrap-like lesions dipping into that. The moment you see vascularization on a large single granuloma, TB would become a big possibility. And when you pass the OCT, besides the granuloma in the choroid, you do see hyperreflectivity in the outer retina, which is a very important biomarker for a possible TB etiology. One of my best friends, Pulido Jose from Wills, is WhatsApping me while Rima was presenting that could it be nocardia because lack of pigmentation bothers me. Well, Jose, this is for you. That's a very good thought. It could be, the lack of vitreitis, the lack of this nocardia should be in the differential. But the moment Rima showed her MRI, we knew it was toxo. But nocardia would be good differential in such situations. And there is a third from Dr. Ahmed Al Janabi, who says, why was fungus not included in the differential? So I think fungus, when it presents with the granuloma, invariably, very quickly, it goes into the vitreous. And we do see something what we call a rain cloud sign, that it's coming from the choroid, going the full thickness, and then going into the vitreous, which makes it to be endophthalmitis. However, you could have a fungal granuloma before it penetrates into the vitreous. But again, as we see in this patient, the CNS involvement and all those were not a feature of fungus. However, all these are important differentials, and thank you for your questions.
Can I add?
Vishali, oh, sorry,
Yes.
go ahead, Rima.
So just one point regarding the differentials of TB and fungal, which ma'am has already said. So the OCT was so characteristic because that was the first thing that we did in this patient. And with the OCT, we had the diagnosis and we just couldn't think of anything else. So the serology report, of course, was corroborative and we had it the next day. So for us, the OCT was make the diagnosis. It's very much unlike fungal. It's very much unlike TB choroiditis.
Yeah, but Jose is WhatsApping me again. Actually, CNS nocardia is also ring-like.
So maybe because we lost the patient after that. The
Yeah,
patient, we don't know what happened.
but they all would remain important differential in case the patient is not doing well in future. Yeah.
Yeah, I think just a quick comment here. When you see something like that in the back of the eye, it looks like a big lump in the back of the eye. So your thing is to say, where's the primary problem? So if it's choroid or retina. And that is a really important thing because if you have a TB lesion, it's going to be primarily a choroidal big lump in the choroid. The retina will get involved secondarily. And as Vishali said, we learned a lot from you, Vishali, the use of anti-VEGF to treat these big granulomas with RAPs. They respond so well to that because of lots of VEGF being produced by these big granulomas and all that. But you don't see this full thickness retinitis that you see in the toxo case. The same thing with nocardia that Jose is talking about. Nocardia is a subretinal abscess. So it's going to start as an infection coming from the choroid. So the primary site of that is going to be a subretinal abscess, like you see in other infections as well. So there is going to be a difference in that presentation. I think it has to be included in the differential because these are serious life-threatening conditions many times that you have to look for it. But that picture you showed in your OCT of the full thickness retinal involvement with the changes towards the vitreous cavity as well would be much more in keeping with the toxo than a fungal or with a bacterial infection of the type of a subretinal abscess. So I think it is a beautiful case because it is a very atypical, aggressive presentation in someone young who suddenly presents with this very large, massive lesion in the back of the eye. So, sometimes you have to think potential lymphomas and things like this. It can present very weird masses also that can be involving the subretinal space or intraretinal as well. So, but anyway, yeah, great case. Thank you.
And the last point I would like to add, in a patient like this, you diagnose toxo, it's responded, but few months later you see it evolving into something. Don't fall in love with the diagnosis of toxo, because even infections like nocardia would initially respond to sulfur, you know. So always keep your options open, and every time there is a recurrence, please do a fresh workup looking at the everything. Don't just continue with the previous diagnosis, especially when the cases are atypical like the kinds we are showing today. Thank you.
Good. So this was a life-saving diagnosis, I think, as well. So very important to sort these things out. So thank you, Professor Rima, and thank you, Sumedha. So next we'll move on to Professor Simar's case that Dr. Manu, his fellow Dr. Manu Sharma will present, White Dots with a Hidden Foe, Fundus Manifestations of Pediatric Cryptococcosis.
Thank you, Dr. John and IUSG for this opportunity. And I think from one dangerous life-threatening diagnosis to another, and what is specific to this case is what we saw, such nice multimodal imaging aiding us in diagnosis in the previous cases. This is a pediatric case of a 1.5-year-old child where let alone imaging, examining the child at that age is a task. So let's see how the case presented and how we could reach a diagnosis in the same. Manu, please.
Okay, sir. Hello, everyone. Hello, everyone.
Yes,
So-
Manu,
Hi there.
please
Yeah.
go. Yeah, perfect. Go ahead.
Hello, ma'am. So my case is 1.5-year-old male child admitted to advanced pediatric center with fever and generalized body swelling. Parents noticed decreased visual attention for 2 weeks and referred to our center. Patient was admitted 2 months back and diagnosed as nephrotic syndrome with hypertension with suspected bacterial peritonitis and anemia, and he was started on prednisolone in view of nephrotic syndrome. Birth history was uneventful. On general physical examination, child having pallor and periorbital puffiness. And on ocular examination, he was not fixing and following the light. These are the red cam images at presentation. Here you can see these blue arrows. There was multiple whitish subretinal lesions, and there were some pigmentary changes in the macular area along with the dull foveal reflex. And you can see some white-centered hemorrhages all over the mid-peripheral retina. Similarly, in the left eye, there were multiple whitish subretinal lesions along with white-centered hemorrhages, and there were 2 other lesions along the superior temporal arcades. They were elevated. So to summarize, it was a 1.5-year-old male child with nephrotic syndrome with fever and decreased visual attention, had bilateral subretinal lesions with white-centered hemorrhages, right eye more than left eye with foveal involvement in the right eye. So we made the differentials on the basis of white-centered hemorrhages and subretinal lesions. We kept the possibility of anemic retinopathy, infective endocarditis, alginic spots, so hypertensive choroidopathy, and immune complex deposits. So pediatricians were planning to give pulse steroids for the nephrotic syndrome. So they again referred us for the clearance to give pulse steroids. But we went saw the patient after 2 days, there were increase in the lesions. Now you compare with the 2 days photograph on red cam, they were increase in the lesions, these whitish areas, they have increase in number as well as in the area. And these white-centered hemorrhages were also increased. Similarly, in the left eye, you can see compared with the previous photograph, the lesions were increased in the number and size. So we did ancillary investigations that day only, fundus fluorescein angiography and the OCT. FFA was done on red cam under topical anesthesia because child was so sick that we can't give general anesthesia to him. These are the fundus fluorescein angiography images. You can see in the early phase, they are more hypo or hypofluorescent lesions as compared to the fundus photograph. The lesions are much more evident on the fundus fluorescein angiography. In the late phase, we can see the lesions were turning from hypo to iso. They were taking the stain in the late phase, but there was no vascular leakage and no disc hyperfluorescence. Similarly, in the left eye, the lesions were staining. And the lesions, this PD kind of thing we have seen along the superior temporal arcade, there was pooling. So it was probably a pigment epithelial detachment. We did the OCT on flex OCT under topical anesthesia. It is very difficult to get, but somehow we could get some scans through these whitish lesions. So what we found, there was disruption of the outer retinal layers. There was hypertransmission suggestive of local focal RPE loss, along with loss of the ellipsoid zone and the external limiting membrane, along with cystoid macular edema in the right eye. Similarly, in the left eye, you can see when the line scan passing through those subretinal lesions, there was focal loss of the outer retinal layers like ellipsoid zone, external limiting membrane, and the focal loss of the retinal pigment epithelium. So we asked them to rule out the infective foci, or hypertensive choroidopathy also kept down the differentials because of the nephrotic syndrome, but it was unlikely because there was no other changes suggestive of hypertensive retinopathy. So we asked them to not to give steroids, and the systemic workup was done, which was suggestive of predominantly eosinophilia. So they did parasitic workup, which was negative. They also did Betioff test, peripheral smear, viral markers, ascitic fluid, but nothing was suggestive of any infective pathology. A child has splenomegaly on ultrasound with bulky kidneys. They planned for blood culture and bone marrow biopsy. The bone marrow biopsy did reveal the cryptococcosis with eosinophilia, and subsequently the blood culture report also came and it revealed Cryptococcus neoformans. These are the cryptococcus on bone marrow aspirate smear. Similarly, in the imprint smear and the pass positive smear, there were multiple cryptococci were seen. Similarly, in the bone marrow biopsy smear, there were multiple cryptococci on the pass as well as reticulin stained, which is specific for cryptococci. They also did the MRI brain, and it also showed the hyperintensity in the periventricular white matter, suggestive of cryptococcal infection in the brain. So they made the diagnosis of disseminated cryptococcosis with eosinophilia and shifted the patient to the immunology department for the further workup. And the nephrotic syndrome, they said it is secondary to the disseminated cryptococcosis because it is also documented before. The treatment was given, patient was started on liposomal amphotericin B and flucytosine for 6 weeks, followed by fluconazole. And patient was having normal blood pressure on 3 antihypertensives. And for the proteinuria, they give stress dose, half-dosed oral steroids. And you can see these are the base. They were the markedly improvement in the blood parameters. Eosinophil count has dramatically reduced, and his kidney functions were also improved. The urine protein and urine creatinine also came down. These are the follow-up scans. You can see there is the definitive decrease in the lesions subsequently, decrease in the number as well as the size, and they become more demarcated. These are the follow-up scan in the left eye. There is a decrease in the lesion size and the number. This is the OCT scan. Although the cystoid macular edema in the right eye persisted with impending macular hole, but you can observe in the left eye, there is the restoration of the outer retinal layers. Although in a child under topical anesthesia, we could not pass the scan through the same area, but still we can see there was the loss of outer retinal layers in the previous at presentation scan, and here we can see there is a complete normal restoration of the normal outer retinal layers. In the immunology department, the various immunological workup was done to rule out the primary immune deficiency, but they could not come to a conclusion. They also did the whole exome sequencing and found this variant of uncertain significance for focal segmental glomérulosclerosis. But they have further planned to rule out the Mendelian susceptibility to mycobacteria by doing all these investigations. Thank you.
Thank you. Thank you so much, Manu, for presenting that. If you could unshare your screen now.
Yes, sir.
So I'll just take you to the thought process that was going on behind the scenes to what Manu showed as a very fairly simple presentation of the disease. So this was when the child was actually diagnosed with nephrotic syndrome. They presented with edema, diagnosed with proteinuria, And the pediatric nephrology diagnosed the child as steroid-sensitive nephrotic syndrome, and they started on 2 milligram per kg steroids for 6 weeks, followed by tapering to 1.5 after a response. And then subsequently, on the 1st of December, since November, the child was having this generalized swelling and some diminution of vision for 2 weeks before the child presented back to the pediatric nephrology department. And on the 1st of December, the child was admitted with them for fever, diffuse swelling, as well as loss of vision. And this was the battery of investigation that they had already done before they actually sent the child to us, which already showed the eosinophilia and the high total leukocyte count. The hemoglobin was also low, and the blood pressure was high, which they were trying to manage with antihypertensive. They had hiked that up also. And this is the point at which our opinion was taken. There is some background to this. So, nephrotic syndrome, a lot of these children we see day in, day out for the complications of steroid, for cataract, for glaucoma. They are routinely sent to the eye department to check whether there is any loss of vision due to that. But this was one child that we had just 2 to 3 months prior to this case. So this is a totally different case. Please don't confuse that. But this one presented with posture-like retinopathy in both the eyes. This was steroid-resistant nephrotic syndrome, which had again presented in a very similar way to them. After they started the steroid, the child presented to them with worsening of vision, persistence of the edema, and no response to their therapy. So this was posture-like retinopathy. So this is the point from where we said that this is posture, this is likely an immune response, and you need to give pulse IVMP. And this child responded very nicely to the pulse and then was subsequently shifted to steroid sparing agents. So when this child was referred to us, this was probably what was going on in their mind. The consultant talked to me directly that, is there something similar? What is happening here? Do we need to start the child on pulse IVMP? So, so is this another immune phenomena, or could this be related to hypertension? These were the two primary questions that were written when this child came to me. And we had 3 pointers which were available. One, that is, this is likely a case of steroid responsive nephrotic syndrome. That was hypertension on treatment, and there is eosinophilia. So these were 3 things in mind when we actually saw the child. The anterior segment had no inflammation, but that was something that we could document on indirect by going close to the eye and with the 20 diopter lens. The patient had a clear media. So these 2 things were very clear, that there was no inflammation inside the eye at least. There were white-centered hemorrhages, which were very striking. You can look at these with hemorrhages with a white center. So this was very striking. And along with these multiple subretinal diffuse white dots that Manu also eloquently showed. And there were no other signs of hypertensive retinopathy really. So there was no disc edema or any macular star or anything like that. The macula was more involved in the right eye, and that is where the child was more symptomatic. You can see this lesion over here, whereas the left eye macula was relatively spared, and these 2 PED-like lesions. So at this point of time, based on the 2 prominent findings that we could see, we said that, okay, we are seeing white-centered hemorrhages. And given the kind of history that you have, it could be a leukemia or anemia related. So we need a detailed blood workup. It could be an infective focus. Infective endocarditis is something we most commonly associate these with. So that is what I actually wrote that down on the card, that yes, this might be there. And then there was these subretinal white dots, which were along with confusing us. So were these 2 the same things? We thought of early Elchnick spots, which are present earlier, and then they ultimately pigment out. What the typical description is central hyperpigmented and peripheral hypopigmented spots. Or were these some kind of immune deposits, mutes? The age is completely atypical for that. So these were just some thoughts that we wrote to them. And then we did some extra ancillary testing, and Manu showed this. This was something which told us that this is an ongoing process. 2 days later, while they were still working up, we called the child back that, okay, let's do some more imaging and try and tie these spots down as to what level these are. Are these choroidal? Are they subretinal? Are these RPE? Because all we can tell from the photograph is that it's in beyond the inner retina. It could be outer retina, it could be RPE, it could be choroid. So we said that let's do some more imaging. So at this point, we noted that yes, over the 2 days, 48 hours, this child was worsening already. Both the white-centered hemorrhages as well as these whitish lesions were increasing in number. And the imaging kind of showed us that they were kind of blocking the fluorescence from the choroid, and they were hypo to start with. These all hypo lesions are corresponding to these whitish areas, and ultimately they stained in the later phase, but they did not leak. So yes, that was something that we could tell from this. And the OCT, of course, uh, it was difficult to do in this case, holding that child down and trying to pass a scan. But you could see these disruptions in the outer retina, RP, and the hypertransmission, indicating the RP loss at that point, and some amount of edema, which I'm sure was more in the center, but we could not pass a scan right through the foveal center in this case. So repeated back and forth between us and the pediatric department. Pediatric hematology also got involved. So we said, yes, IVMP may not be the answer here. It is a very different disease from the one we saw earlier. We should look for an infective focus and the cause for eosinophilia, control the hypertension, and consider a peripheral blood smear and a bone marrow biopsy to see the cause for the eosinophilia. And repeated blood cultures were being sent by them to find the cause for the infection. And of course, the bone marrow biopsy was the first one to give us a diagnosis, which was very clear, where they could show these ring-like lesions, which were suggestive of cryptococcosis, and they did multiple scans to differentiate them from the other ring-like lesions, and they could prove that, yes, this is actually Cryptococcus neoformans is what we are looking at in the histopathology. And then we kind of reviewed the literature. So this was at no point in our differential diagnosis while we were seeing the patient that, yes, it could be Cryptococcus. So this is all retrospective. We reviewed the literature after that, and we could find a few reports of Cryptococcus choroiditis or chorioretinitis, which have been described in literature, though the youngest child described is about 9 years of age. So no one this age that we could find. And these were the kind of lesions that we could looking very similar to the ones we have, though a lot less in number than what we could see. We can see these lesions. This was a HIV positive case in which they could see this, and this was a more diffuse lesion in which another case report which was described with some disruption. The only OCT scan which I could find with some disruption of the outer layers and involvement of the RPE. So yes, as they were thinking that the original nephrotic syndrome itself was caused by the Cryptococcus infection. So there is some evidence to support that, yes, Cryptococcus can cause nephrotic gate proteinuria, and these were some cases that have been described in the literature. So unlikely that the steroid treatment that they gave actually caused this. This was all along a primary diffuse cryptococcosis, which kind of manifested itself more after getting the steroids. And something that they are now looking at and trying to find out, as Manu described, is the cause for the immunodeficiency. They've ruled out all the commoner things, but the primary immune deficiency, the severe combined immunodeficiency, and these disorders is something that they are actually looking at to see what is causing the immunodeficiency in this child. So just a few take-home points from my side. One is never ignore a child's complaint. They rarely complain, especially when it comes to the eye. So if a child is saying something is wrong, means something is wrong. Cataract and glaucoma are not the only cause of low vision in nephrotic syndrome. You can have something like this, which is you need to look at. Not all steroid responsive nephrotic syndrome is idiopathic. You can have infective causes which could be causing that. So yes, you should be looking at that. Atypical white dots like these, when you see, as we are seeing in this case, along with the white-centered hemorrhages, I would give more credit to the white-centered hemorrhages here that led us to think of the infective focus more rather than the white dots. Infective etiology should be kept as a differential, and this picture is kind of looks very typical for cryptococcus coming from the blood into the eye. And disseminated cryptococcosis in infancy and in the young children is a red flag for inborn errors of metabolism, and you should inborn errors of immunity, I'm sorry, and you should try and look at it from that point to rule out primary immunodeficiency in such a case. And severe eosinophilia should also prompt evaluation for parasitic infections is something we all know of, but hematological disorders, immune dysregulation syndrome, and most importantly, fungal infections, as in this case. Thank you so much.
Thank you very much. So another beautiful case. I don't think I've ever seen cryptococcosis occur without immunodeficiency. I was just scanning online and it looks like that can happen, but the large majority, I think, of these cases would be immunodeficient. So we'll see what happens, especially such a young child. Interesting, they could, like, I wonder where they would acquire it from, at this age. But anyway, something interesting to think of. Yeah.
Simar,
Vishali.
I'm reading out again Pulido Jose's message, which is very interesting. He says, can this patient have a primary hypereosinophilia syndrome as a cause of immune deficiency? Because these hypereosinophilic syndromes, they are a heterogeneous group of rare disorders with clinical manifestations that have a wide range: fatigue to life-threatening endomyocardial fibrosis, thromboembolic events. So I think we can look at hypereosinophilic syndrome as a cause of primary immune deficiency as well, though I'm sure our pediatric team will look into it, but it's a good comment. So I thought I'll share with you.
Absolutely, ma'am. Anything's open at this point, but this child did have a very good response to the amphotericin B and the fluconazole treatment that the child received. And the eosinophil count also came down from 24,000 absolute eosinophil count to about 2,000 by the end of 3 months that follow-up that we have. So that's the only point, that yes, the treatment somewhere is working, what we gave to the child, looking at the fundus as well as the systemic status. But still, we are still looking out for the cause of the immunodeficiency in this. They're trying to find what primary immunodeficiency this child could have. We could not find any secondary cause to that.
Yeah, that's what that hypereosinophilic syndrome is a cause of primary deficiency.
Yes.
We can explore.
Absolutely.
Over to you, Carlos, for your comment.
Well, yeah, it's a very rare case. I don't think I've ever seen anyone this age with Cryptococcus choroiditis. But again, back to the HIV time, we saw patients with Cryptococcus meningitis, and many of them presenting with multiple choroidal lesions, which was an important diagnosis. And a lot of the times, optic disc swelling as well, because they might have intracranial hypertension. But it was something we saw more. And many patients presenting with skin lesions. Very typical, a bit umbilicated, diffuse the skin lesions, which would give you the diagnosis. Just taking the biopsy from the skin, you could also find the cryptococcus there. So it is, I think, the rod spots, the white-centered hemorrhages that you describe. Really, we had a patient recently presenting with a subretinal abscess, a lesion that looked like subretinal abscess with a lots of rod spots around. So that for me closed the diagnosis in terms of this is a bacterial infection disseminating from somewhere, and we need to find it. So it's a question of looking at the heart, looking at liver, looking at places where this can come from. But this is a very different situation. This is a child, maybe Jose is absolutely right. I don't know much about this primary eosinophilias to say how they present, but clearly they can produce immune deficiency and clearly opens the door for this disseminations of uncommon pathogens. And the question that John is asking is very valid. How did this child get in touch with cryptococcus at this young age? It's an interesting question to ask. But yes, it's this kind of multifocal choroidal, and the fact that the outer retina was recovering as presented in the images, there was a recovery. It's telling you the primary problem was the choroid. Actually, that's where it was, and affecting the outer retina and producing changes that are reversible after that. So if you had the direct destruction of the outer retina, probably recovery wouldn't be the same as you're describing there. So it's another element to show where the problem is. But this is an important case because it really highlights the need to for me, cryptococcus means immune deficiency. If I see something happening in the eye, I will go for finding something. So today we had 3 cases in which the immune system was the culprit here of allowing diseases to behave badly, isn't it? So it's a good teaching point of the immune system failing opens the door for disasters and makes the diagnosis much harder because the presentations become uncommon and atypical. So we need to really have in mind that this, whenever we see something behave in a weird way, look at how the immune system is working. Thank you, guys. Amazing, amazing cases. Thank you.
Simar, Jose is responding to your comment that ampho might cause eosinophils to decrease because ampho is so toxic, but it could be something else that caused immunosuppression. So please give follow-up. Jose, we will send you the.
Absolutely. Absolutely.
So,
I
yes,
wonder if
John,
we can
you may
put,
conclude. Yeah, you may conclude and
yes,
announce next one.
okay. So I was just going to ask if the tech team can put Jose on as a panelist, because it would be interesting to hear his remaining thoughts. Um, so do you, could could um could we just discuss, like, what other features might have shown a systemic infection, as was like an endocarditis, as was initially thought? I suppose you would be finding it with like echocardiography and so on, but those would be very important findings to have, but you typically wouldn't have these deep white lesions. So that
Absolutely.
was a very important observation.
The,
Does anyone
yeah,
have any? Mhm.
both the things were kind of not matching. So again, infection, again, gave more importance to the white centered hemorrhages, but then again, they were just in the right eye. The left, both the eyes had those whitish lesions. So that was a learning for us that yes, this can present with this. So based on the OCT and the imaging, I think it would be fair to say that this came in from the choriocapillaris into those areas.
Mhm.
Yeah.
Good.
I think, John,
Yeah.
the issue of the choroidal lesions, I think this multifocal appearance of the cryptococcus is very different. Usually, if you have a primary bacterial source elsewhere, dissemination hematogenously spread to the eye, it would not produce typically these multifocal lesions. It tends to be more a proper abscess somewhere in the back of the eye rather than this. Of course, the raw spots, yes, there'll be multiple in the back of the eye, that's fine. But in terms of the choroidal involvement, you don't tend to see these multifocal small lesions in the same way that you see in cryptococcus. This is very typical. Even your fluorescein showing those dark spots. This is
Yes.
very typical of the cryptococcus when you see them in the fluorescein. Of course, the ICG shows even more obviously the abnormality, but the fluorescein can give you a clue.
I think what again is extremely important is the clinical examination. I'm sounding like a record which is broken record, but this patient was diagnosed as nephrotic. They wanted to increase the corticosteroids, and Simmer just happened to look. And if you give a casual look into the eye, the changes, whatever you are seeing, they could very well be due to hypertensive choroidopathy. And you could just pass it off in a 1.5-year-old child that, okay, go ahead and give steroids. It was picking up those white spot hemorrhages which raised a red alarm that, well, this could be infection. And they looked at the infection because if the child did not have any other symptoms. So if they had gone in the direction of nephrotic, immunosuppressing him further, we might have lost the child. So this comes again to the importance of paying attention to the clinical examination. Thank you, Sima.
Welcome back.
I tend to be a little bit of a, low adopter and low user of technology, but everyone watching this seminar today can see that having thorough imaging of the cases was extremely important to figuring out what was going on. Like, I remember Dr. Vishali's case, where you have so many things happening in the fundus and you see a little patch in the periphery, and that's the key to the diagnosis. So probably, you're not going to see that easily by indirect unless you're super capable. But to be able to have good imaging and sort of spend some time mulling it over, I think is increasingly what we're kind of needing to do as uveitis specialists. And so just wanted to make that point. Could the team share the flyer for the next the next conference?
John, you going to announce the winner of the last one? Because usually you announce the winner this
We
one
did,
of the
we
previous
did.
one.
We did announce the winner of the
Oh,
last at the beginning.
okay.
I'll
Okay.
announce it
Yes.
again for those
Good.
of us who were not there in the beginning. We did announce the winner from the Singapore team, Tani M. Brown, who presented the case of Behind the Veil of Inflammation, Unmasking a Clinical Imposter. And whenever our book on IUSG Grand Rounds is ready, Tani will get the complimentary copy of it. Over to you.
Great. Okay. Can we have the flyer back up again? I guess
Can
the
we have
flyer
the
can't make
flyer?
noise. So maybe you can see it as one of the participants here. Anyway, let me see
Is
if I
our
can make it
technical
up.
team there? Can you put the flyer on display?
So meanwhile, and
So like,
Yeah, perfect. Got it.
it's on 11th of
perfect. Yes. So we're trying to provide a monthly case conference, probably skipping during the summer or the Northern Hemisphere summer. So our next one will be April 11th. And I would just like to note for those of you that are in areas of the world that change from standard to daylight time, will be changing to daylight time by then. So the timings will be a little bit different. It's keyed on 5:30 p.m. in India. And so I think basically it will be an hour later, I think is right for those places that are shifting to daylight time. So just make note of that. And the team from, I'm sorry that I can't pronounce French, but from Pitié-Salpêtrière Hospital in Paris, led by Bahram Bodagi, will be taking the lead, another one of the famous centers in the world. And we look forward to a very interesting case series or case presentation series once again. So thank you very much, everyone. And I think this concludes. I did put I wasn't sure if everyone could see the link for the third basic IUSG course in Africa. So I put it in the answer to Stefan Thoreau's question. So maybe I'll just leave this open for a little bit so that you can write that down, but it would be iusg.net/the-third or three -IUSG-basic-course-in-Africa. So hopefully some of you will have the opportunity to come and take advantage of that. Several of us here are faculty for that, and always a good experience. So does anyone else have any concluding thoughts?
Thank you, everyone.
Okay. Well, thank you. Have a wonderful
Thank you,
day.
guys. Thank you very much. Beautiful
Okay.
cases. Thank you.
Thank you. Yeah,
Thank
thank
you,
you for
Bye.
joining, Carlos. All right. Thank you.
Thank
All
you.
right. Bye-bye.